Thank you, Roxana. So I've been given this opportunity to debate my mentor, my colleague, and we work in the same lab together at WashU, and we do the same kind of procedures and we help each other, so it's not very fair. So Dr. Sharma likes that though. Anyway, I'm going to talk about intravascular lithotripsy. These are my disclosures. And so these are 4 cases that I did in the last couple months. And if you look at it, they're all calcified, they're all messed up. And how do we treat those? And I'm going to make an argument that intravascular lithotripsy is the mainstay of treatment of all these scenarios. So I'll try to, if I have time, I'm going to go over these cases. I have little snippets at the end. So, okay, so intravascular lithotripsy, for those of you who are not familiar, it's actually a pretty simple to use device. So moderate to severe calcification is seen in a lot of patients that we do in the cath lab, and even more elderly patients that we tackle, right? You know how much atherectomy is used in these patients? Less than 5%, right? That's why calcium is your enemy. That's why the TLR rate, stent thrombosis, all those things are very, very poor. Because the learning curve, people are afraid. There are complications, all those kind of things. So now if we have a device that can actually take away all that fear and has good data, then why would you use atherectomy, Professor? Tell me. Okay, good. All right, so this is how it works. It actually is a balloon. It's filled with 50-50 contrast. It has electrical energy. Then when it interacts, it actually creates this sonic pressure wave, this acoustic wave, which is pretty close to about 50 atmospheres, and it actually breaks. Why is this not playing? Okay, there you go. So you can see there, it's hard on hard and soft on soft. If you put a hand, you get the electrical thing, nothing really happens. But it's a bony material there, it just breaks it, and that's how it really works. So you can see in the OCT, it actually, you can pull back, you get multiple fractures. You not only get superficial fracture, but you get medial fracture. And what happens when you get medial fracture? You could change the compliance of the vessel, right? What do you want to get? You're going to get minimal stent expansion, right? It is not only dependent on superficial calcium, it's dependent on how compliant your vessel is. And so this is very important. That's why I think this is more attractive. Not the other atherectomy devices don't really do that. All right, there is data, disrupt studies 1, 2, 3, and 4. A lot of data has been published. You can see there's consistent results all throughout in terms of procedural success. You can see, as John said, and it'll show you that sometimes it doesn't cross, but there are things that we can do. The complications are much, much lower. The Disrupt 3 was recently published. It was based on the performance goal, primary safety endpoint, 30-day MACE, and effectiveness in 384 patients. And you can see here, the in-hospital 30-day MACE was compared to all the other studies, and then it met the primary safety and effectiveness endpoint. So you can see here, ease of use. You don't want to be 5%. There was no evidence of learning curve. So the roll-in patients, most of the doctors who really enrolled, that was one of their first cases, they didn't have to learn too much. It's just a balloon. So that is very, very important, right? No learning curve. And you can see it's one of the most safest. It's not really atherectomy, but calcium modification tool. And you can see compared to orbital, rotational, the Prepare Calc and Rotaxis trial, the complication rate of severe perforation, dissections, and all those things is much, much lower. So how about calcium nodule? Dr. Keeney showed calcium nodule. You can see in this cartoon here, you can see how it orbits, the orbital, how rotational has wire bias. What if your nodule is on the other side? It really depends on where your wire is. When you pull back, how much wire bias you change, you can do that. But it's very, very complicated, right? It's very, very complicated. But actually, if you looked at the calcium nodule subset here, most of them are in the right because it's tortuous, and that's how the nodule forms. The LED was pretty much non-nodule calcium. You can see the stent expansion with IVL was uniform across the board. So you worked in both, like here, both in calcified nodule and in non-calcified nodule. Okay, so you can see the calcified nodules here, OCT, so you can see a deformed eruptive nodule, then you have a deformed nodular calcification and non-deformed, and you can see across the board you have decent minimal luminal stent expansion with shock waves. So it actually does not only medial stuff, but it actually changes and causes those microfractures in the nodule also. So the other thing that's very interesting, if you remember, females have very large amount of complications with atherectomy devices, especially calcification, smaller vessels, and a lot of different factors involved, but they have complications. You can see here, the maze, bleeding, all those things are much, much higher in females. So if you look at the pooled analysis from the DISRUPT studies, females, men versus women, you can see pretty safe in women versus men. Comparative procedural success was very, very similar. And you can see serious complications, not too bad. So very, very similar in females. This is one of the ones that really shows you that females do as well as male in non-atherectomy calcium modification shockwave. Atherectomy is really not. So larger studies need to be done, obviously. Endpoints were very, very similar. So in real world situation, you can see here, I'm not going to go over this algorithm too much. I don't have time. But if you see here, all these roads, never mind you're uncrossable, you won't expand, you come here, all the roads lead to lithotripsy. And here you can see, non-compliant balloon, people used to use mild calcium. Severe calcification doesn't work. IVL, dog boning, high-risk patients, thick, deep calcium, left mains, osteals, bifurcations, and now I added nodular and females on there. The only scenario, atherectomy, is uncrossable lesions and diffuse calcification, which I will show you. So this is my slide that I made up. This is the scenario. Left mains, there is data that minimal stent expansion with shockwave is much, much better than just atherectomy and a balloon inflation, okay? It has about 93.7% you actually achieve the minimal stent area in left main, which is very important. Bifurcations, obviously, you can have 2 wires down, you can do shockwave bolts, osteal lesions, pretty simple to use, deliver with the guide. ACS patients, they have a lot of calcium, a lot of LD. If you look at acuity and Horizons AMI, a lot of people actually presented with acute coronary syndrome with calcium. They have platelet clots, some of them have fibrin-rich red clot. What does atherectomy do? Embolizes stuff, right? Here, you put it in there, you don't embolize, and that's why it's very attractive in this scenario. Large lumen, wire bias, no problem with guttering and perforation, obviously atherectomy failure, and calcific underexpanded ISR, like we showed here, and female sex that we talk about. As I said, long lesions and failure to cross are the only scenarios, all these scenarios. So I'm not 100%, but I'm 98% IVL. So Professor, it's going to be all yours. So I'm going to stop here. Ease of use, no learning curve. Excellent safety profile, excellent data, promising in both concentric and nodular calcification, promising in female subsets, ACS patients, more studies needed in ISR, and then limitations in long lesions and uncrossable lesions. So I'm going to show you a quick case here. This was one of the cases that I showed you. Patient presented with ACS. Okay, this was one of my cases. So you can see this is as bad as a calcium gets. So how do we do this? It's very hard to, very hard to wire, and it's very hard. We wired it, but we actually couldn't even cross a microcatheter to go down. So what do? We listened to John, and we just wired with a flex wire, the CSI flex wire, and then we did CSI. And you'll see here, it has a balloon pump already transferred from an outside hospital. So we did CSI, and then after CSI, look what happened. It is such bad calcium that your balloon actually is still dog boning. So this is atherectomy failure, okay? So what do? You do this. You do shockwave, you expand it, you IVUS it, mark the ostium on IVUS. Your IVUS will show you here, I'm not going to go over it. And you can see we protected the circumflex, and that's your final picture. And that's what shockwave does. This is atherectomy failure, but you can use these cases really together. So very, very important. I'm not going to show the next case here, but what I'm going to do is, see this case, everything is occluded. What do? Atherectomy, probably problem. So you do shockwave here, on the circumflex, open it up, no flow limiting dissection, good luminal gain, and then it gives you time to do whatever you want to do. So we did that, and I'm going to go over this thing. The thing I want to really show you is the last case that I showed you, this case here. So see here, right coronary artery is calcified, osteal, and you can see you are not coaxial. And these are the things that you have to be really careful in doing atherectomy. No other device will really work. So here, you are starting the atherectomy device in the cusp. You can dissect the cusp, cause AI, or you can do what you did there, perforation. And this is, I think, scenario where shockwave really works very, very well. You take it down, even if it doesn't go, take a balloon in there, get your guide coaxial, and do it, and your case is done. So I'll stop here. Thank you very much.